It is essential to always use a systematic approach when reviewing any X-ray to avoid missing significant findings. The ABCDE approach provides a consistent framework that can be applied to all types of X-rays. Before you can accurately identify abnormalities, you must know normal anatomy thoroughly. Whenever previous studies are available, you should compare them with the current film to detect any interval changes. Clinical correlation is absolutely essential, meaning the X-ray findings must match the clinical picture you have obtained from the patient's history and physical examination. The very first step in your review should always be a quality assessment, where you check the patient's details, the positioning, and the exposure of the film. Step A is the airway assessment. On chest X-rays, you should trace the trachea from the larynx down to the carina where it divides. The trachea should be positioned in the midline, or it may be slightly deviated to the right at the level of the aortic arch. You must look for any tracheal deviation from this normal position, as well as any signs of compression or the presence of foreign bodies. Assess the patency and caliber of the airway throughout its course, as narrowing may indicate tumors or strictures. On neck X-rays, you should specifically evaluate the upper airway for any swelling or masses. It is critical to remember that any airway abnormality requires immediate attention and further evaluation, often with more advanced imaging. After completing the airway assessment, we then proceed to step B, which is the breathing assessment. This involves a thorough examination of the lung fields for symmetry, volume, and parenchymal patterns. You should identify the horizontal fissure on the right side and assess its position to ensure it is normal. Look for any evidence of consolidation, which appears as opacification, as well as collapse, masses, nodules, or interstitial patterns. Carefully check the costophrenic angles, as any blunting of these angles suggests the presence of a pleural effusion. You must also assess lung volumes, noting hyperinflation, which is seen in chronic obstructive pulmonary disease, or reduced volumes, which may indicate fibrosis. It is essential to compare both lung fields systematically, moving from the apices down to the bases. Step C is the circulation assessment. You should begin by evaluating cardiac size using the cardiothoracic ratio, which should be less than 50% on a standard post-aero anterior film. Assess the cardiac borders, including the right atrium, the left ventricle, and the aortic knob. Look for any mediastinal widening, which may indicate aortic injury or the presence of mediastinal masses. Check the hilar regions carefully for enlargement, calcification, or any abnormal contours. Examine the pulmonary vasculature, noting if there are increased markings which would suggest heart failure and pulmonary venous hypertension. Finally, assess the position of the aortic arch and the course of the thoracic aorta. Step D focuses on the diaphragm assessment. Both diaphragms should appear dome-shaped with smooth, well-defined contours. The right diaphragm is normally positioned 1 to 2 centimeters higher than the left due to the presence of the liver beneath it. You should look for any elevation of the diaphragm, which may indicate phrenic nerve palsy, eventration, or subphrenic pathology such as an abscess. Check for flattening of the diaphragms, as this suggests hyperinflation typically seen in chronic obstructive pulmonary disease. Assess the costophrenic and cardiophrenic angles to ensure they are sharp and well-defined. Additionally, you must look beneath the diaphragms for the presence of free air, which suggests perforation of a hollow viscus, and this is best seen on erect films. Step E encompasses everything else that needs assessment. You must thoroughly examine all visible bones, including the ribs, clavicles, scapulae, and vertebrae, looking for fractures, lytic or sclerotic lesions, or signs of degeneration. Check all soft tissues, including the neck, chest wall, and axillae, for any swelling, subcutaneous emphysema, or masses. Review the upper abdomen, noting the gastric bubble and the shadows of the liver and spleen. You should also look for any medical devices such as lines, tubes, pacemakers, or surgical clips. In female patients, assess the breast shadows for symmetry and the presence of implants. Finally, do not forget to review the commonly missed areas, which include the lung apices, the region behind the heart, and the subdiaphragmatic areas. Moving on to chest X-ray specific considerations, we must first address technical quality assessment. You need to check the penetration of the film, and the vertebrae should be just visible through the cardiac shadow. Assess for rotation by ensuring that the medial ends of the clavicles are equidistant from the spinous processes of the vertebrae. Verify that the degree of inspiration is adequate, and at least 8 to 9 posterior ribs should be visible above the diaphragm. Evaluate the exposure to ensure there is adequate contrast between the lung fields and the surrounding soft tissues. Confirm that all labeling is correct, including the patient's name, the date of the study, the laterality markers indicating right and left, and the patient's position such as erect or supine. If the study is of poor quality, it may need to be repeated or supplemented with additional views. When it comes to common pattern recognition on chest X-rays, you should become familiar with several distinct appearances. An alveolar pattern appears as fluffy, coalescent opacities that often contain air bronchograms, which are air-filled bronchi outlined by opacified surrounding lung. An interstitial pattern appears as reticular, nodular, or linear opacities throughout the lung fields. A nodular pattern consists of single or multiple rounded opacities of varying sizes. Cavitary lesions appear as air-filled spaces within the lung, and they may have thick or thin walls. Pleural-based abnormalities include pleural effusions, pleural thickening, pleural plaques, or pleural-based masses. Mediastinal abnormalities include widening of the mediastinum, the presence of masses, lymphadenopathy, or pneumomediastinum, which is air within the mediastinal space. Let us now consider the specific example of a pneumonia pattern. Pneumonia typically appears as a focal area of consolidation with air bronchograms present within it. The consolidation may be lobar, meaning it involves an entire lobe, segmental, or patchy in its distribution. The silhouette sign is a valuable tool that helps localize the opacity, and for example, right middle lobe consolidation will obscure the right heart border. Airspace disease without associated volume loss helps distinguish pneumonia from atelectasis, which typically does cause volume loss. Of course, clinical correlation is essential, and the patient will often present with fever, cough, and an elevated white blood cell count. Follow-up X-rays should show improvement in the consolidation with appropriate antibiotic treatment. Another important example is the pattern of pulmonary edema. In cardiogenic pulmonary edema, cardiomegaly is often present with a cardiothoracic ratio exceeding 50%. Kerley B lines may be visible, and these are short horizontal lines seen at the lung peripheries, indicating interstitial edema from distended interlobular septa. Peribronchial cuffing may be present, where the bronchial walls appear thickened due to fluid accumulation. A classic appearance is the bat wing or butterfly pattern, which represents central alveolar edema that spares the lung periphery. Pleural effusions are common and are often bilateral. The rapid onset of pulmonary edema suggests a cardiogenic cause, while a slower onset may indicate non-cardiogenic causes such as acute respiratory distress syndrome. The pneumothorax pattern is another critical finding to recognize. The key feature is the presence of a visceral pleural line that is visible running parallel to the chest wall. There is an absence of lung markings peripheral to this pleural line. On supine films, you may see the deep sulcus sign, where the costophrenic angle appears unusually deep and lucent on the affected side. In a tension pneumothorax, there will be mediastinal shift away from the affected side, which is a medical emergency. A small pneumothorax may only be visible on expiratory films, which can make the pleural line more conspicuous. Accurate assessment of the size of the pneumothorax is important for guiding management decisions. When approaching abdominal X-rays, a systematic approach is equally important. You should assess the bowel gas pattern, noting the distribution of gas, the caliber of bowel loops, and the thickness of the bowel wall. Look carefully for any evidence of free intraperitoneal air, which will be visible under the diaphragms on erect films. Check for abnormal calcifications throughout the abdomen, which may represent renal stones, gallstones, or an appendicolith. Evaluate the outlines of the solid organs, including the liver, spleen, and kidneys, as well as the psoas muscle shadows. Examine all visible bones, including the lower ribs, the lumbar spine, the pelvis, and the proximal femurs. Finally, review the soft tissues for any masses or abnormal fat planes that may indicate pathology. The bowel obstruction pattern is a common finding on abdominal X-rays. You will see dilated bowel loops proximal to the point of obstruction, with collapsed loops distal to it. Small bowel obstruction is characterized by dilated loops located centrally in the abdomen, with valvuli conniventes that are visible as thin lines crossing the entire lumen of the bowel. Large bowel obstruction shows dilated loops located more peripherally, with haustra that do not cross the entire lumen. You may be able to identify a transition point where the dilation changes abruptly to normal caliber. Signs of strangulation, which indicates compromised blood supply, include thumbprinting from mucosal edema, pneumatosis or air within the bowel wall, and portal venous gas. Serial films can show progression and help determine whether surgical management is needed. The perforation pattern on abdominal X-ray is another critical diagnosis. The hallmark finding is free subdiaphragmatic air visible on an erect chest or abdominal X-ray. Wriggler's sign occurs when both sides of the bowel wall become visible due to the presence of air both inside and outside the lumen. In supine infants, you may see the football sign, which is a large oval lucency over the abdomen representing a large amount of free air. Air may also outline the falciform ligament or other intra-abdominal structures. Clinical correlation is essential, and the patient will typically present with sudden severe abdominal pain and signs of peritonism. This finding requires urgent surgical evaluation and intervention. For musculoskeletal X-rays, a systematic approach is also necessary, and we use the ABCS approach. A stands for alignment, where you assess the normal anatomical relationships at each joint. B stands for bone, where you examine cortical continuity, bone density, and the trabecular pattern. C stands for cartilage, where you assess the joint space width, its symmetry, and the condition of the subchondral bone. S stands for soft tissues, where you evaluate for any swelling, joint effusions, or displacement of fat pads. It is essential to have at least two views, and often orthogonal views taken at right angles to each other are needed for complete assessment. Fracture pattern recognition is a core skill in musculoskeletal radiology. A fracture is identified by a visible discontinuity in the bone cortex. You should look for any abnormal angulation, displacement, or rotation of the fracture fragments. Associated signs include the presence of a joint effusion or soft tissue swelling around the injury. There are special types of fractures to recognize, including torus or buccal fractures in children, which are incomplete fractures of the bone cortex, greenstick fractures where one cortex is broken and the other is bent, and stress fractures which are hairline fractures from repetitive microtrauma. Complications to watch for include involvement of the growth plates in children, which can affect future bone growth. As a general rule, always check the joints above and below the injury site. Pediatric X-rays have several important considerations. The normal appearances in children differ significantly from adults, including the presence of the thymic shadow in the chest and unossified epiphyses at the ends of growing bones. Bones in children are more plastic, making greenstick and torus fractures more common than complete fractures. You must be vigilant for patterns of non-accidental injury, which may include multiple fractures at different stages of healing. In children presenting with respiratory distress, consider congenital heart disease or respiratory infections as possibilities. Abdominal emergencies in children include intussusception, malrotation, and necrotizing enterocolitis in neonates. It is crucial to recognize age-specific normal variants to avoid misinterpretation. There are several common pitfalls and artifacts that can lead to diagnostic errors. Skin folds can mimic a pneumothorax, but unlike a true pneumothorax, skin fold lines extend beyond the chest cavity and do not have a visible pleural line. Clothing, jewelry, and hair can create artifacts that overlie anatomical structures and obscure pathology. Rotation of the patient can cause apparent mediastinal shift or make one lung appear denser than the other. Poor inspiration can make the lung bases appear hazy, mimicking lower zone consolidation, and can also make the heart appear larger than it truly is, simulating cardiomegaly. Breast shadows in female patients can obscure the lung bases. Finally, normal anatomical variants are frequently misinterpreted as pathology, emphasizing the need to know normal appearances thoroughly. Comparison with previous studies is an essential component of X-ray interpretation. It is crucial for detecting subtle changes or progression of disease over time. You should compare the size of any lesions, nodules, or masses to assess for growth or stability. Look for the interval development of new abnormalities that were not present on prior imaging. This comparison also helps evaluate the response to treatment in patients with known conditions such as pneumonia or heart failure. It aids in differentiating chronic findings, which are stable over time, from acute findings that are new. Therefore, you should always make every effort to obtain prior imaging studies when they are available. Knowing when to request additional views is an important part of radiology practice. Oblique views may be needed to better visualize rib fractures or to confirm pulmonary nodules that are questionable on standard views. Lateral decubitus views, where the patient lies on their side, are useful for quantifying the size of a pleural effusion and determining if it is free-flowing or loculated. Expiratory films are valuable when a pneumothorax is suspected but not clearly seen on inspiratory views. The swimmer's view is a specialized projection used to visualize the lower cervical spine and cervicothoracic junction when these areas are obscured on standard views. Stress views may be necessary to assess for ligamentous injuries in joints, such as the ankle or knee. Contrast studies, where contrast material is administered, should be considered when plain films are inconclusive. Integration of imaging findings with clinical information cannot be overemphasized. The patient's history should guide your search pattern, whether it involves trauma, fever, chest pain, or dyspnea. Physical examination findings should correlate with the radiographic abnormalities you identify. Laboratory results, such as white blood cell count or cardiac enzyme levels, can support your radiographic interpretations. Serial imaging is often used to monitor response to treatment and guide ongoing management. For complex cases, multidisciplinary discussion involving radiologists, clinicians, and surgeons is invaluable. Never interpret an X-ray in isolation from the clinical context, as this can lead to significant errors. Clear communication of your findings is a professional responsibility. You should use unambiguous terminology in your reports, avoiding vague or confusing language. It is important to distinguish between definite findings and observations that are merely suspicious and require further investigation. Provide a differential diagnosis based on the radiographic appearance, listing the most likely possibilities in order of probability. Suggest next steps, which may include additional imaging modalities, clinical correlation, or follow-up imaging at an appropriate interval. Any urgent or unexpected findings must be communicated directly to the treating clinician, not just included in the written report. Finally, document your findings clearly and thoroughly for medical legal purposes. It is also important to recognize the limitations of plain radiography. Plain X-rays have low sensitivity for early disease or subtle findings, meaning a normal X-ray does not always exclude pathology. The superimposition of anatomical structures limits visualization and can obscure important details. Plain films provide poor soft tissue contrast compared to computed tomography or magnetic resonance imaging. They cannot reliably differentiate between different tissue compositions in the way that computed tomography or magnetic resonance imaging can. The quality of the study is highly dependent on technical factors and patient cooperation. Therefore, plain radiography often serves as a screening tool that may require further imaging with more advanced modalities for definitive diagnosis. In summary, the key principles of X-ray interpretation should always guide your practice. You must use a systematic approach consistently, and it is helpful to develop your own personal checklist to ensure nothing is missed. You need to know normal anatomy thoroughly and also be familiar with common normal variants that can mimic disease. Always compare with previous studies whenever they are available to detect interval change. Correlate your findings with the clinical presentation to ensure they make sense in context. Recognize the limitations of plain films and know when it is appropriate to seek additional views or advanced imaging. Finally, commit to continuous learning through regular case review and feedback from colleagues to continually improve your interpretive skills. Thank you for watching. Don't forget to like, share, and subscribe. See you in the next one.